All right, great. Well, thanks for joining us today, everyone. We're really excited to have Dr. Cameron Gettel here. Dr. Gettel is an assistant professor in the Department of Emergency Medicine at the Yale School of Medicine and a clinical investigator at the Yale Center for Outcomes Research and Evaluation. Dr. Gettel aims to advance the understanding of emergency department care transitions in the growing geriatric population through the identification and development of patient and caregiver-reported outcome measures, and then to design, implement, and validate innovative care transition strategies and interventions to improve clinical outcomes. His work is funded by the NIA GEMSSTAR R03 mechanism, the NIA IMPACT Collaboratory, the Alzheimer's Association, the Emergency Medicine Foundation, the Yale OAIC Pepper Center, and the Geriatric Emergency Care Applied Research GEAR networks. Dr. Gettel earned his undergraduate degree in biochemistry from Elizabethtown College and his Doctor of Medicine from Penn State University College of Medicine. Most recently, he completed emergency medicine residency at Brown University, where he served as chief resident, and the National Clinical Scholars Program at Yale University. So, Dr. Gettel, we'll let you take it over.
Awesome. Thanks, Sarah. And thanks for having me, everybody. Appreciate the audience and the chance to have a discussion here. I've worked with a few folks from Northwestern in the past and excited to cross-pollinate and get to meet other ones as well today. And so when Eleanor asked me for a title about this maybe 4 to 6 weeks ago or so, I was sort of thinking about the work I'd done and a little bit of a play on, emergency physicians sort of difficulty focusing or sort of all over the place, sort of scatterbrain the stereotype, if you will. And so I've tried to stay focused like any good researcher should, but I've still sort of had tangential things that have sort of gone out. And so the hope is today I can sort of share a little bit of sort of the health services research work that I've done, as well as particularly focused on aging policy research and outcomes as well. So again, thanks for having me. Really appreciate being here. A few disclosures on the slide that Sarah mentioned just based on my funding. And then the objectives, I want to just talk about outcomes, aging, and policy in that order. And sort of around the idea that why should we care about this in general, sort of I see the emergency department has sort of been described as sort of a sentinel event. And so older adults coming in, persons with dementia, their care partners, it's an opportunity for them to maybe reduce that hesitancy maybe that they have in the outpatient setting and sort of realize that maybe there is a problem that brought them there for the acute illness, and maybe they're more receptive. And so that's sort of the framework with which I operate under. Just a little bit of background about who I am and sort of what I do. I made this slide before, but it sort of just shows sort of how I've sort of developed sort of about that focus idea I mentioned, sort of some of the domains that I work in. I started residency in 2015 and did some first work in falls in the geriatric space, and sort of did a little bit of work care transitions. I had a great mentor, Liz Goldberg at Brown, in residency, and I looked at nursing home to emergency department care transitions, and that was sort of one of the professional reasons that got me interested. I'd have these patients, after hours, after 5 p.m., when I worked the majority of my shifts, come in. EMS wouldn't necessarily know the reason why the person came in. The person maybe was cognitively impaired, or because of their acute illness, they couldn't tell me. Family maybe didn't know that they were even in the ED. And if I called back the facility, they inevitably would have had a shift change. And so they wouldn't necessarily know. And so this idea of care transitions really sort of stuck with me and is really the glue that sort of holds my work together. Did some work, qualitative methods, systematic reviews as well. And then sort of in fellowship in 2019 to 2021, I started doing a little bit sort of this idea of sort of focus and sort of policy stuff. I did some work in Medicare policy, which I'll share a little bit on. With the, when I came to Yale then in 2019, I met Mary Tinetti, and her work with the patient priorities care sort of got us to have a conversation about, can the idea, the 4Ms framework, the age-friendly health systems, is that possible to be introduced in the emergency department setting? And so sort of a little bit of work around that. And then, as fellowship went on, then I started to get interested in persons living with dementia, persons with cognitive impairment, and their care partners. They experience, obviously, things differently. And then outcome measures. I sort of also operate under the credence, the mantra, if you're not measuring it, you can't improve upon it. And so I've really sort of thought about, okay, how are we measuring things? That's sort of a lot of the work I'm doing. And then how can we improve upon that through intervention design, as Sarah had read in my bio. A little bit on pragmatic clinical trial design, and then sort of going in the where I'm sort of going now, a little bit of digital health, I think there's a lot of change since COVID, a lot more acceptability potentially of telehealth or of text message kind of interventions. And so I'm thinking about that in the way of pragmatic trials. How can we provide support to care partners after ED care and sort of give them the services they need in the way that they might want it. And then sort of more traditional health services research, out-of-pocket expenditures. I've got some data which I'll share in the middle there about what do out-of-pocket expenditures look like for older adults, and then the idea of home time as well. And many of you are probably familiar with home time, sort of the idea about getting people to be in the setting that they want to be in. They don't want to be obviously in the ED or hospitalized or in rehab facilities. And there's been a lot of movement over the last 5 to 7 years or so about days at home, home time, whatever you sort of want to call it. And so we have some data that we're also sort of starting to get together with that. And then a little bit out of left field, the role of private capital, private equity, and that's a discussion for maybe another day, but also sort of getting involved in that conversation, as it definitely impacts the care that we provide older adults. And nursing homes particularly have been impacted by that, but I have some interest in that as well. Great mentors, Liz Goldberg at Brown, Arjun Venkatesh is my chair here at Yale. He was a Northwestern medical student, and Eula Wang. Eula is my mentor here at Yale, and she just recently moved to NYU, but we've collaborated a lot, and I have great appreciation for all of them. Just a few grants that I shared on the prior slide. So a lot is sort of on, the first two are sort of on outcome measure development, and then a little bit on intervention design, and then some other analyses that I'll talk to, or maybe briefly touch upon some national geriatric ED descriptive sort of health services research stuff. Some of the stuff at the end will also be in the Medicare Current Beneficiary Survey. If any of you are familiar with that, the MCBS has a lot of great outcomes and really has been historically underutilized in the ED space. And so I'm really excited sort of doing the data management, thinking about analytic plans, sort of getting some things up and running there, which I'll share some information on out-of-pocket costs there. So topic one, outcomes, I really, with this sort of focus thing, I actually had like 3 sub sections that I want to talk about in each broader topic, but I figured that would probably be way too much time-wise. So I've cut it down. I think I have 2 in each topic. The first one, I just want to briefly share some of the findings about what matters in the ED. And then I'll share some of the work we've done over the past 2.5 years on developing outcome measures, if you're unfamiliar with that science. So what matters? I came to Yale in 2019 pre-COVID and got, like I said, married Snetti in the bottom left corner. This was a Yale Pepper Center, a small grant through Yale. So they supported me a little bit to get a research assistant. And we did a qualitative study to look at what matters to older adults in the emergency department. And just a little bit of topic background. Older adults and they often receive goal discordant care, critical care, end of life kind of issues, but then also in other phases of acute care and hospital care and non-acute care as well. And like I mentioned earlier, the John A. Hartford Foundation, IHI, stood up the age-friendly health system. I think about 2016 or 2017, and really at the core of that was the 4 M's framework, as many of you are probably familiar with: mobility, mentation, medication, and then in our case, what matters. And also sort of unknown, sort of related to that is, okay, so older adults have things that matter to them. Are clinicians, are their perceptions of that, are they aligned with that? Are clinicians in the ED setting, are they even picking up on that? Or is it too hectic, too time sort of sensitive that they're just totally glossing over or ignoring it? And so presenting or identifying a feasible approach to this, what had not been shown before. And so before my time, Mary had worked with, Dr. Cincinnati had worked with a few other folks, other stakeholders across the ED space and the patient priorities care space, and really had sort of drilled down the work that she had done in the outpatient setting to sort of 2 critical questions that could be asked in the emergency setting, and sort of really got to the crux of the issue. First being asking a question about ascertains the older adults' fears or concerns about being in the ED and sort of their healthcare at that time, and then also about what is their desired outcome. And so this was sort of the framework with which we operated. And then we asked at the bottom, you can see similar sort of parallel questions to the treating clinicians. And so research assistant gathered that information, we timed it, and then we sort of looked at themes across what we were identifying among older adults and then also among their treating clinicians. And you can see for the older adults, this is one of our tables, the fears and concerns to that first question. You have the typical themes that you might expect. What are their concerns? symptom cause identification, those kind of things, what's the cause. But interestingly, then highlighted in red is not infrequently, in fact, frequently, was sort of their concerns that even came out in the acute phase of preserving their current status, particularly with mobility. You can see some of the quotations there. I want to be able to take care of myself. I don't move much at home because I have a hard time getting up and moving, but sort of that rang true in a lot of the qualitative interviews that we had. And then the second question of that was about outcomes. What outcomes are they most hoping from? I guess I would classify myself as an outcomes researcher, and so this is definitely of interest to me, but sort of related to that prior concern was this desired outcome of maintaining self-care and independence, and this isn't unique to the ED space. Obviously, this is something that carries over and is a longer standing concern or desired outcome of older adults. But it was interesting to see if this is brought up in the emergency department care in that space. Is there something that we could do that's related to the acute illness to sort of assist them with maintaining self-care? I wanted to better take care of myself, those kind of things. I used to love to walk, and sort of with the acute illness now, this person was unable to do that. And if there's a way that we could identify that or improve upon that, that would be a possible spot of intervention. And so from that work, one of the things we found was, the research assistant asked the patients those questions, and it was really quite feasible to do this in the ED space. There's a time and place, and to get to sort of the heart of the issue, I think can be done. The mean time was 3 minutes. And so you could really get some issues that really have substance and really matter to the patient within a very short time period. And overall, there were similar concerns and desired outcomes. The clinicians relatively frequently identified what they thought the patient was concerned about, what they thought their desired outcome was. But they really didn't, those two red boxes that I highlighted, they really didn't have a sense or really prioritize or think, as you may have hypothesized, about their older adults' concerns about overall function and daily life and mobility and preservation of status and those kind of things. That was sort of maybe one would say lost on those ED treating clinicians. And so from this, we proposed that, I think this is a conversation that could and should be had. There's relatively limited downside, but sort of identifying, particularly, this is a framework that you can identify older adults' concerns and desired outcomes within the ED encounter and see if there is a spot of intervention, whether that be through social work or case management or services or physical therapy. There's definitely opportunities and systems in place in certain EDs. Transitioning a little bit now, the second part of that outcomes research bucket is some of the work I've done here in early faculty. When I was a fellow, I applied for a GEMSSTAR award in the second half of my fellowship. I was awarded that, and so this work here has been the first little bit beyond 2 years now of faculty developing and validating PCROs, patient and care partner reported outcome measures. Like I said, if we're not measuring it, then I don't think we can improve upon it. And so you're probably familiar with some of this data. Older adults account for over 23 million emergency department visits. It's about 20% of ED visits nationally. Most are discharged home. I think maybe about 60%. And that time period, similar to a post-hospitalization, that time period after an ED visit also imparts considerable risk, functional limitations. There's been work that's been shown, as well as other adverse events in the way of mortality or ED revisits. However, really few, if any, effective care transition interventions exist post-ED. But care transitions have really had a lot of considerable increasing relevance for the older adult population as the population grows. In the past 8 to 10 years, there's been the geriatric ED guidelines, which have been put forth, multidisciplinary engagement, and has really tried to standardize and reduce the variation of geriatric ED care and to provide some recommendations. And then in the past 6 years, the American College of Emergency Physician, ASAP, they've had a geriatric ED accreditation process, which again has really put forth guidelines and suggestions and protocols for implementing policies to improve the care of older adults seeking emergency care. And sort of related to what I'm going to talk about in the coming slides, outcome assessments have really been the easier things, the administrative outcomes that are captured, ED revisits, hospitalization, mortality, those kinds of things. But really, there's really has failed to take into account salient sort of patient-reported outcome measures that matter to them. And so when I was a fellow, there was one of the opportunities through that I met Yule Wang with was the GEAR network, which Sarah had mentioned up front. It's called the Geriatric Emergency Care Applied Research Network, and this was, I think, an R61 and R33 award from NIA, sort of an infrastructure grant, and then first phase being to identify research priorities, and that's what we did, and then the later part were to provide pilot funding to studies that investigate those priority areas. And so when I was a fellow, I worked with several people and looked at, among older adults, cognitively intact, what are the priorities, what are the research priorities in the emergency department space for care transitions for those older adults? And what we ultimately determined was that sort of across all stakeholders, again, multidisciplinary, first off, the order was determining optimal outcome measures was, and that was the most pressing need. And that's really what shaped my desire to pursue this for a GEMSSTAR award. And then about a year later, they also had funding. EULA and some other MPIs had parallel funding for GEAR 2.0, which was advancing dementia care. And so there was similar, there were sort of 4 domains. It was care transitions was one topic, medication safety, elder abuse, delirium. There was a handful. I'm not remembering them all right now, but I, again, given my interest in care transitions, was on the care transitions group for this team. And we published, again, sort of the research priorities. And again, the 2 things that really stood out were, first off, interventions. So what interventions improve outcomes for emergency departments of community care transitions for persons with cognitive impairment and their care partners. And then what matters most to those. So outcome-wise, what matters most to those, and how can those priorities be measured? And again, that's sort of what fueled my path forward in the funding routes I applied for. And so the objectives in taking that into context, I think any good application needs a good acronym or a catchy one. And so what I proposed to do in my GEMSSTAR was to develop this thing called a promoted tool, the patient-reported outcome measure, older adult care transitions from the ED. And that was based off that prior work that I had done. The goal was to develop a tool through a multi-phase process, which I'll share in the coming slides, and then to conduct internal validity testing of the promoted tool. And when I say sort of develop a tool, that's an instrument, a survey. You can think of it sort of in a few different ways if you've had any experience with that. And then at the bottom of the screen, then outside of the GEMSSTAR, then I was told work smarter, not harder kind of thing. And so I repurposed some of that science, repurposed the population, sort of changed things a little bit, and then targeted that to a care partner sort of lens. And so we came up with the COMET tool, the caregiver-reported outcome measure for emergency care transitions. And sort of similarly, to develop this tool, since their outcomes, since their priorities, the care partners, are going to be different than persons, older adults cognitively intact. So this is sort of the visual that I sort of think about the two parallel projects with. On the left is the promoted tool. The older adults are cognitively intact. So that was one population. When we approach people in the ED, we sort of have studies that they can sort of go down either of these avenues based on their cognitive status or their diagnoses in the record. And then on the right is the COMET tool. So those that are cognitively impaired. And for both of these, first phase, which I'll share, is qualitative interviews, sort of how has the care transition been? We talked to them a few days after the ED visit, sort of see what went well, what could have been better, what barriers they experienced. Item generation, again, this is sort of that survey science. Item generation, looking at the available patient-reported outcome measures in the literature, pulling from them, changing them, tweaking them, making them more specific to the ED, and then also potentially generating new items, that new questions, new items, based on the step above, the qualitative interview. So how did that sort of inform our item generation? That's sort of the next step. And then third is member checking, where we have these items, we have maybe 45, 50 items for both cases, and say, hey, stakeholder here, you're the end user, which of these are really important? How important is question 1, question 37 on a scale of 1 to 5? Should this be included? And then we had some quantitative data as well to go with that qualitative. And then cognitive debriefing step is just a step where you have these items, these candidate items, and you're assessing comprehension. Does this question make sense? Should it be reworded? Should anything be added or subtracted? These are sort of all, I didn't make these up. These are just based on best practices for sort of patient-reported outcome measure development. And then finally, for both, we finished with a technical expert panel. So we convened about 15 to 20 people for each tool. Again, multidisciplinary, across stakeholders, nurses, care partners, older adults, emergency physicians, geriatricians, researchers, across the like, and had a 3-phase, which I'll share in the coming slides, sort of 3 phases about these are the items. This is how they were rated quantitatively. This is sort of what we think. And then we'd have discussions and sort of back and forth about, okay, sort of getting to the final tool. This is reaching consensus agreement kind of thing. And then the phase we're in right now is we have this tool for both of them. Now we're going out and doing the validation phase where we're doing this, like we're getting the data back, and then we'll ultimately do psychometric property testing to see its reliability, ceiling effects, inner item reliability, all those kinds of things. And so I'm just going to go through a little bit of the findings on just briefly on each of the on a few of the steps here. And in the top right corner, sort of just to keep us oriented, to sort of serve as a signpost, if you will. So this is for these findings are for the older adults, so the promoted tool, those cognitively intact. And so the first phase there about qualitative interviews and sort of what did we find with the qualitative findings? There's 4 themes. I showed 2 on this slide and 2 on the next slide. And as you can imagine, the ED discharge process was really abrupt, lacked explanation, really about their test results, their labs, what was found, and the paperwork was wholly unhelpful, essentially, the cumbersome, lengthy, and you can see a few representative quotes there as well. And then there's a slew of barriers to navigating outpatient clinical care. There's sort of this no man's land of leaving the ED, but I can't get in contact or see my primary care doctor quite yet. Who do I contact? And so sort of some desire in that time period for a follow-up telephone call or some kind of touch base about how they're doing. And it's that care transition is obviously difficult, but this sort of captured for the first time some of the quotes and themes that were identified. And then new physical limitations. And so that was one of the themes, and going slower, mental hesitancy, that was one of the things that was common. Somebody syncopized when they were driving, and they were thinking, they sort of this mental hesitancy again about should I drive or should I not, and it really sort of affected them, even if it wasn't necessarily a physical limitation per se. And then also, and as you probably have experienced in your clinical practices, hesitancy to accept need for support. There was potential frustration from family caregivers that was perceived by the older adult, and very desire or need for formal or informal support. So that was sort of interesting to delve into. We published that in JAGS shortly after. And then moving on to the third phase, member checking, just to sort of share a little bit more about what this is. So you can see, a few example items on the screen, 3 example items. And so we put these in front of the older adults and said, hey, how important, on a scale of 1 to 5, how important is this question? How important is it to monitor, to assess? And so we got quantitative information from 50 or so older adults. And we grouped the 47 items that we had for this tool into 4 categories, into 4 sort of subdomains: discharge process, care transition, symptoms and quality of life, and functional status and disability, sort of based on the information we were getting from the qualitative interviews, and sort of shaped sort of how we structured this. And then skipping over cognitive debriefing, going to the technical expert panel, this is sort of what it looked like. Again, I think we had 3 interactions with the technical expert panel back and forth before we reached the consensus. And so we went through REDCap with this, and based on the earlier information in the prior 4 steps, then we had a lot of information about each item, about its importance, and then we had a group discussion, and we sort of came to the recommendation of either retain or omit that item. And so then we put that out to them survey, and we wanted to see if they agreed with those recommendations, and that's sort of how we got it down from 47 items down to a more manageable 15 to 20 items. And then they could obviously also provide additional comments if anything else was of importance as well. Just a few screenshots there. And here's just one of the final promoted tool that is out actively being assessed now for validation. And so you can see sort of the different items and sort of how they're phrased, and that sort of has morphed through the different phases of the research. But it's so we're getting information about the care transition itself right now, and sort of what items, what issues are most important to track we have. And then switching a little bit, so we've done the left side now of the figure, now sort of thinking about the right side. So I just want to share a few findings, abbreviated as well, about sort of what we're finding with care partners of persons with dementia or persons with cognitive impairment. There was a bigger focus on the ED environment itself among care partners, and the impact that had on the care transition afterwards. Oftentimes, there were visitation. This was done, I think, in 2021, early 2022, and there were still maybe some visitation policy restrictions with COVID. And also, one of the things that care partners really identified a few times was the potential downplaying of cognitive impairment by the patient. And if they were not able to be there, then maybe the care team, not knowing the person, just sort of meeting them, for the first time, they might think that they are more cognitively intact and more able to follow through with discharge planning, when in reality maybe they weren't. And then when they got home, they couldn't necessarily tell their family member what happened or what the plan was. And ideally, a ED nurse or an ED physician would call and give report and sign out, but and sort of let them know what the plan was. But that was definitely sort of the ED environment itself could sometimes cause a lot of could impact the care transition. And sort of, I guess, sort of related to that, sort of that poor communication was identified not infrequently during the ED discharge process. Competing interests, competing priorities of emergency docs, not really explaining completed testing, the lengthy paperwork that we mentioned earlier for the other population, and again, sort of this desire for a follow-up phone call or some sort of touch base. And that's sort of, seeing this in both that last bullet really, again, that was sort of a moment for me thinking, I mentioned earlier on that slide about sort of the domains that I'm interested in, sort of thinking about, well, how can we do that from an intervention perspective? It seems like something relatively light touch that we could potentially do. I think care partners had more added responsibilities when aiding persons with cognitive impairment, and there was a lot of feelings of obligation, sort of enhancing in-home safety assistance, sort of increased assistance with ADLs, and sort of feelings of guilt as well when they couldn't necessarily do what they wanted. And then navigating the healthcare system after was really quite difficult. Sort of, not just following with PCP, but also sort of getting the community sort of, how do I navigate respite care or changing facility? Somebody's in assisted living or independent living and they need a higher level of care, how to sort of do that, and not being able to sort of get in contact with anybody, and not having been put in contact with some case managers, which may have been helpful. We published that in Alzheimer's and Dementia TRCI. And so I touched upon a little bit of this in there, but the hope is that this provides new insights into the ED discharge process itself. Can identify if priorities are being met, and then also incorporate some of these findings into clinical care conversations. Hopefully it overcomes some limitations of the typical past patient experience measures, satisfaction. And I mentioned earlier about informing subsequent interventions. So we know this information, we know these are their priorities, and we know that this is what they desire. So how can we potentially introduce those? And so just sort of going back to this signpost slide, if you will, a few things in red that sort of outcomes topic sort of touched upon. So I just want to sort of bring back there how that relates to me and my career path. Aging is the next topic, and this is sort of broad, and I want to share just one of the interventions that we developed, and then also some of the health services research we're doing on Medicare current beneficiary survey. This work, so it was informed by the COMET tool development, some of the findings we were finding in the qualitative studies. And so I partnered with a few community partners. Amicus Brain on the left is a health technology company, started focusing on persons with cognitive impairment. They have a lot of great resources and technology sort of integrating, which I'll share. And then LiveWell is a local sort of dementia specialists who also have occupational therapists, as well as other great staff who can help out and with care transitions for this example. And so this funding was pilot funding from the Gear 2.0 network, which I mentioned. And so we wanted to, in short, develop an intervention for this population, and then see what the feasibility of a tech intervention and artificial intelligence intervention is, and sort of see what that looks like, see if there is any actual adoption and if any preliminary efficacy. So this is just one of the figures that I made for the grant, and it sort of just lays out the aims, thinking about, in the first aim, we do qualitative interviews and focus groups to sort of think about the role of technology in the ED care transition intervention. And then we also did this thing called a design thinking workshop, which pulled persons with cognitive impairment and their care partners, and really is used in the business space more often, relatively nascently in healthcare. But it's one that really pulls in the end users in the intervention development, because so often we see intervention implementation and uptake down at the last stages not really be as high as we'd like, and it's probably a result of the development phases. And then aim 2 is more the supports, which I'll share. I know these icons probably don't mean too much to you, but I'll sort of show the specifics of what does the intervention actually do, and then tracking the outcomes. And so NuvaCare is the name of the artificial intelligence, and it sort of is meant to be sort of, I'll just go through these, is meant to be sort of supportive and provide resources for care partners of persons with dementia. And that's through enabling ordering of tests of external resources, text message support through the task support service advisor, about advice. Resource advisor is sort of, are there local things about respite care programs? Are there elder care law attorneys? Are there, I need a diagnosis. My loved one has a, memory problems. I need a diagnosis. Who in the area can sort of do that? And so it's powered by AI in that regard. And so it can direct care partners to some of the things that they need. And then the advisor is, my family member has symptoms at 3 a.m. and I can't talk them down. What can I do? And then finally, the community hub is a space where members or people with this technology, they can get peer support. They can talk to other care partners who have a loved one or a family member with a similar situation. They can sort of talk about strategies and course and so it's a really great peer support network. This is just a few screenshots of the resource advisor, for example, and the way that care partners are interacting with this, and what type of resources are you looking for? Okay, I want home care and assisted care, and then you can plug in their address, and then they can get places within a few minutes of them. They can get their website, they can get their telephone number, they can get information about that, and sort of how to get connected to services, whether it be the area agency on aging or other resources as well are available to them. The care coach intervention then is the second arm of the intervention, sort of the second component, if you will, and that's through Live Well, and they provide occupational therapy trained professionals, sort of a touch base with the care partner, usually at 1 to 2 days after ED discharge, and then 8 days later, and then we track outcomes at day 7 and day 30 through this pilot that we're actively completing right now. One of the phases was a design thinking workshop, which we pulled maybe 20, we were fortunate to get maybe 25 people together for about a day and a half, where we really we had this prototype from Amicus Brain. They had developed this in the outpatient neurology setting for folks with cognitive impairment and dementia. And so we're adapting it to the emergency department space and hearing their experiences and what could be better and what they would need. That's sort of how we did the design thinking workshop. And for those that are unfamiliar, then we sort of, it's very interactive. It's getting Post-its up, sort of having discussions and sort of, sort of dreaming, what's the dream scenario? What would an ideal scenario look like? And how can we sort of ideate and sort of prototype towards that, which is really quite interesting and a skill I hadn't had before. And then sort of just some other pictures from the work we've done. And we published this in JAGS recently, and the hope is that it's really more of a guidance. It's not just for care partners of persons with dementia. It's more thinking broadly. Hopefully it's translatable for other PIs, for other researchers who are designing interventions and want a way to engage stakeholders in a meaningful way. And so we have a few lessons learned. I think we have 10 lessons learned about different opportunities and things that we learned through that process. So far in that work, we started enrollment maybe about 6 to 7 months ago. We have approached a lot of people. We've enrolled a few people. There are some are just point blank just not interested for whatever reason. Some are interested. We've had maybe, I think I just got a report this morning, I think we have about 20 to 25 complete by now. And so people are, understandably, there's reasons for refusal. And so they're focusing on their acute illness. Something is going on. We don't really want to worry about this thing right now. They're too busy. They're not really interested in technology. So we're sort of trying to overcome those and tweak sort of our framing and sort of all this stuff and seeing how we can potentially provide them with services if they're interested. And so it's an interesting process to sort of think about that. What's also interesting is some of the outcomes that we're tracking, and you know, they complete the surveys and follow-up information at day 7 and day 30, and we get the baseline information as well. Some of the outcomes that we're thinking about and we've tracked are the Pertinsky caregiver self-efficacy, the 4-item Zerich caregiver burden, as well as then at the bottom some measures on, is the technology, you know, the technology component, is that of interest? Is it acceptable? Is it appropriate? Is it feasible? Those kind of things. So we have some interesting information. Then, should we want to later, we've considered like an SBIR proposal in the past as well. So this could provide preliminary data for that if we decide to collaborate and go further with this. But, you know, of interest, it is sort of, you know, these are early signals, but, you know, we're seeing a little bit of a trend toward increased caregiver self-efficacy and maybe a little bit of decreased caregiver burden. So that's the goal. And we'll see as we get more numbers if that holds true. So a few implications there. Co-creation of novel intervention, I think, was really exciting to sort of see that from the ground up. Some preliminary, you know, early positive signs. We'll see if that holds true. This is a study as well, sort of that fits, I think, in that aging bucket that I mentioned. This is with Nikki Hastings from Duke, collaborating with her again. Bottom left corner. This is a Pepper Center. So this is actually funded through the National Pepper Center, the coordinating center, and this was one of the multi-center pilot awards, fortunately, that was awarded this past cycle. So it's 2 institutions. So Nikki and I are collaborating, and she and her team have a lot of great experience with MCBS. And so we proposed 2 aims in that. One is looking at home time, the idea of home time after emergency department care. And then the other is looking at healthcare expenditures, so out-of-pocket costs, given the robust information that MCBS has. And so in this work, I'm going to share the second aim. That's, I'm sorry, the first, the out-of-pocket cost is what I'm going to share today, because that's farthest along. The home time is still undergoing a little bit of data management right now. But a little bit of background on costs and how that sort of relates to this. You know, I think we've all know Medicare Advantage enrollment is really increasing in recent years in comparison to fee-for-service. And so there's really little information that exists about costs around emergency department care, but there's also really little knowledge existing about comparing MA and fee-for-service as well. So that's what we sought to do. We used 6 years of MCBS data, repeated cross-sectional. We pooled the results as well then. And we looked at total and out-of-pocket costs of treat and release ED visits, just because it's difficult to sort of parse out. I don't think it's possible to parse out the costs of ED care when it's rolled up into an admission. And so we had to sort of solely focus on treat and release. And then also we touched upon catastrophic costs. There's a few definitions of catastrophic costs out there. The one that we used was 10% of out-of-pocket expenses of your annual income. If it's greater than 10% of your annual income, that'd be considered catastrophic. And so I just share a few across the years here. On the top is Medicare fee-for-service beneficiaries. We had about 5,000, and the bottom is Medicare Advantage. We had about 2,600, and you can see sort of an increase in Medicare Advantage proportion over the years. The median, this is for ED costs itself, the median total cost over those years is about 420, and you might think that this is low. You know, a lot of the prior work that's been done has also included hospitalized patients, and so they're sicker patients generally. They undergo a wider workup, more imaging, etc. And so this actually sort of does fall in some of the realms, the like supplemental tables of things that I've seen on treat and release ED visits for earlier data. And then out-of-pocket costs, you can see the out-of-pocket cost median as well, made up about $40, $45, $50 for both Medicare Advantage and fee-for-service. But the more interesting part is when you look at the proportion that's out of pocket is actually considerably greater for MA. So we split people on the right are those that had an ED visit where their primary payer, they were enrolled in MA, and on the left are those where the ED visit where the primary payer, they were enrolled in fee-for-service and not MA. And in pink, you can see the out-of-pocket proportion. So their overall cost, say, was $500. And so the vast majority of that was paid on the left, was paid in purple by Medicare. And then a smaller portion, I think on the order of maybe 10 to 15% across those years, was paid by out of pocket. But then over on the right for MA, even though the total cost was less, the out of pocket proportion cost sharing was considerably more, which was an interesting finding, and one that I think stands somewhat with the literature that's going on about MA. It's sort of an interesting field to be in right now. And then we did ED visit itself, and we also did 30 days before the ED visit, that sort of time frame. How does it sort of lead up to the ED visit itself, and then sort of after as well. So this is the before, and we saw sort of similar trends as well, sort of this increased cost sharing sort of across the board for before the ED visit, and then also on the next slide as well after the ED visit as well. So some of our implications that we find from this work, Medicare Advantage now makes up about 40%. This was in 2020, the latest, 40% of treat and release ED visits in a nationally representative sample, and catastrophic costs for the period 30 days before ED visit itself and 30 days after was met by about 3% of beneficiaries. So 3% of beneficiaries had more than 10% of their annual income just within that 60 days, which if you prorate that income to just 2 months, that's even going to be a considerably higher amount. But overall, as you sort of saw, that total and out-of-pocket costs really remained relatively stable, which is actually in line. There was a recent New York Times piece that came up sort of about Medicare and the costs, and it's actually sort of stabilized in the 2010s. It has remained relatively stable. And then a higher proportion of emergency care related costs was out-of-pocket, so more cost sharing for MA enrollees. And sort of bringing it back to this signpost slide, a few sort of red things is sort of where that work in aging has sort of centered around. I'll be quick then on the last section about policy. I sort of wanted to include this as well because I do a little bit of policy work as well. And if anybody's familiar with the MIPS, the merit-based incentive payment system, or MIPS value pathways, and how quality is conducted and how payments are decided to either be penalized or rewarded to clinicians. We'll talk about that a little bit here. And then some of my work as well. I work for, I do some contract work for CORE, Center for Outcomes Research and Evaluation at Yale. And we think about and do the methodology for the STAR ratings program. And the hope is like these things in together, I share these because this really impacts how care is delivered on a broader scale to older adults, and how the quality that we provide can provide more globally improves quality to older adults. So as a fellow, I started this MIPS performance work. Just by very quick background, a lot of shift in physician reimbursements toward value-based care. The merit-based incentive payment system, the MIPS, is sort of how we, by default, have our quality measures assessed by CMS, and then, like I said, rewarded or penalized. So there's 4 categories at the bottom. Quality is the most heavily weighted. And this sort of dictates quality for older adults seeking care is sort of the question that this answers, and particularly for emergency care. And so we use publicly available Medicare data. We looked at 2018 and all EM physicians or clinicians participating in MIPS, and thinking about the big thing was, there's all these quality measures that are available that to be scored upon. Are the measures that were scored upon, are they relevant? Do they matter to emergency care? Are they going to move the needle for care of older adults in the ED? And what we found in this heat map is the measure IDs on the left don't necessarily matter to you, but what this showed us was that there's a ton of measures that emergency clinicians are reporting that are scored upon that really don't matter at all to the specialty, that really don't matter at all to acute care. The 3 most common are on the right side of the screen. Things like ischemic vascular disease, the use of aspirin, things like pneumococcal vaccination status. And, you could make the argument that screening for future fall risk is definitely relevant. But I mean, this, as well as the next 4 or 5 were wholly irrelevant. And so the hope is that this shines light, like, are we really moving the needle for older adult care in the emergency department? If we're not really measuring what matters, then how can we improve that? And this is probably a manifestation of emergency clinicians being part of multi-specialty groups. And so all clinicians in the group are reporting the same thing. And that's why this rises to the top. But Where that took us is what the main takeaway was, that the measures are not specific to clinicians within our specialty, but it really took us to the next step, is what are called MIPS value pathways. And this is where CMS is sort of going to address some of those problems with the MIPS program, and sort of develop specialty specific sort of groups of measures to really sort of be able to benchmark and compare across clinicians and really address what matters. And so we convened a group of stakeholders looking at the landscape of available emergency medicine quality measures. And there are the quality payment program through CMS, and there are also emergency medicine specific data registries that we looked at. And we pulled all 50 or 60 or so measures and said, hey, do you think that this should be in an emergency medicine MVP, a MIPS value pathway? Like, do you think that this really rises to the top of our specialty? And so we got some quantitative information again about what was important, what wasn't important. And then we could identify the perceived impact that those clinicians as well thought the certain domains had on clinical outcome, on cost of care. And ultimately what that did is that coalesced several measures that sort of came to be sort of addressing the key topics, the key conditions that we as emergency physicians address. And I sort of led this, and then we put in the MVP at the bottom, MIPS value pathway, adopting best practices and promoting patient safety within emergency medicine. This was approved by CMS. And then the hope is in the next few years that gets rolled down and switches from voluntary to mandatory requirement as MIPS sunsets. And then we can compare clinicians across meaningful things that actually matter and that are our bread and butter. And finally, the last part on policy is the work that I do with Arjun on core star ratings. If you're familiar, the star ratings is a way for consumers to go online and look at the quality of hospitals that they're considering care for. And so we designed the methodology. I've done this past 1 or 2 years about measures that are publicly available, grouping them into things like mortality, safety of care, and readmission, developing a hospital score, and then grouping them with other hospitals, and then determining, okay, who gets 1 star, who gets 3 stars, who gets 5 stars. And like I said, then what that hopefully, the hope is that how that sort of relates back to the care of older adults is hopefully they can get information, reliable information, that can direct them to, hey, this hospital is poor on quality, on safety or readmissions. And so they're just a little bit more in the know about the performance of local hospitals as well. Last slide here, just some ongoing work that I have and future directions, work on restraint and sedation use as well in the ED, thinking about rural with closures of hospitals, how access to emergency department care in general and access to geriatric ED care. How about a usual clinician? How does that impact emergency department use? And we can do some of that through MCBS, as well as some of these other questions on the slide as well, including end of life spending, fragmentation. There's a lot of really great health services research related questions that we can go after. So, like I said, focus. Hopefully, a lot of people to thank, obviously, on the slide here, but hopefully, sort of focused and around sort of a theme, but also sort of a little bit sort of in different areas, like any good researcher. And hopefully, there's a common thread. But I'll stop there and take any questions. It's been a great talking to the group, and eager to answer any questions or collaborate in the future. So thanks for having me.
Thank you so much. That was great. Covered a lot.
Yeah.
Appreciate it. I'm looking around to see if I see any questions, any hands raised. Mike, you unmuted. Do you have a question?
I was just a comment. I think I'm amazed you had time to give this talk today.
Thanks. I wanted to get a lot of stuff out there. I had a lot of good stuff. And I know your group's active and productive, so I figured I'd try to get as much stuff in. But yeah.
Yeah, I mean, I think the ED is always a challenging setting in terms of continuity of care, and our CMO at our health system is Jim Adams is an ED doc, and I know the conversation of how you kind of build a scale and maintain, a lot of your work on measurement, I think, is very, I totally agree. I have a colleague and mentor that for years told me what gets measured gets done. That's the mantra. Yep. But having that, so some of the tools like promoted and that you're using, are you actually implementing them now at Yale? Like,
yes, I mean, that's the question. I mean, that's the next question that admittedly in my GEMSSTAR, I didn't lay out enough. It was more like intervention, and then how does it affect it? But I think the sort of related question in this is like, how do you implement it? Is it through, like, I've had talks with people and they're like, oh, could you consider this as part of the CAPS, the consumer, surveys that people get? Is there a way to introduce it in Epic? Like, is there a way to sort of do that? There are other implementation components of this as well that I think sort of is the next step to sort of think about as well. But not using it yet. It's just for research purposes right now. But we need to, that's sort of the component. How do you sort of get out there? The other sort of one way to sort of go about it that I've thought about beyond Yale is, I mentioned the Geriatric Emergency Department, and the collaborative. There's this GEDC, it's GEDC, and it's hundreds of EDs across the country, and they have to do like certain projects, and some of the geriatric EDs, they have to report on a certain number of outcome measures. And so could I sort of roll that out with them and say, hey, here's an outcome measure. If you track this, this would meet your requirement for a geriatric ED. So there's, I think, implementation opportunities through that vein, through these places that are sort of already interested, have drank the Kool-Aid a little bit. That could be sort of one way to go as well. But I think it's going to be a big build if it's like Epic. And so I don't know how that's going to work out.
No, great. Sometimes when measures give people also the, backing into it, what they should be doing. If they know what the outcome is that they're going towards, what is a ideal geriatric experience in the ED? Well, if you look at your measure, maybe that backs into providing guidance as to what the interventions or how the care flow should actually look like.
Mm-hmm. Yeah. Exactly.
Right.
Any other questions from the group?
If anybody has interest, health services research, I'll just put a plug out. If anybody has any interest, I'm happy to collaborate, think about MCBS stuff. So,
well, we obviously so our Pepper Center has a measurement for obviously work with Promise and the NIH Toolbox are some major thrusts of Northwestern, and so I think a lot of your focus, a lot of what you've discussed is talking about patient-reported experiences and measurements. So that I think would be really interesting to keep conversations going with you on that. A lot of you have a very broad expanse of work. So hats off to you again, to your point. You're really covering a large expanse of health services and healthcare policy research. So that's great. We're also, another part of our center though also is, in complement to it, is health systems design, and thinking about how do you impute technology. So I saw that pop up multiple times in your conversation. So there's a lot of ways where I think there's synergy for us to keep the conversation going. And I may, Danielle McCarthy actually does have a role with us. So I'll definitely, through her, connect and yeah, definitely. But thank you for your time. This is great.
Yeah, thank you for having me. Sincerely appreciate it. Thanks again.
Thanks. Take
Happy
care.
Friday.
Bye-bye. Thanks all.
Bye, everyone.